Good evening, everybody. We have two surgeons today. One is the speaker, Dr. Shreyas Gajjar. He is an arthroscopic surgeon, sports and orthopedic surgeon at Kokilaben, Dhirubhai Ambani Hospital, Mumbai. He does arthroscopy procedures mainly and received fellowship training in procedures in most of the joints from UK and Australia. He's efficient in sports medicine and surgery related to sports injuries, and has treated several professional sports persons and celebrities. And he is also a member of various arthroscopy societies and regularly invited as faculty in the National Arthroscopy conferences. On the panel, we have Dr. Henry Dushan Atkinson. He's also a good friend of mine. He's a consultant orthopedic surgeon in London since 2009 and specializes in lower limb surgery, sports surgery. And he's a divisional director of surgery at North Middlesex University Hospital and visiting professor of Belgrade University Medical School and assistant professor of St. George's Medical School in London. And he's editor-in-chief of Orthotays. Orthotays is actually a very good source for trainees in orthopedics. And he's published over 250 articles. Thank you very much for joining us. I'll let Dr. Shreyas start with his talk.
Okay, thank you, Srinivas. And it's good to connect with old friends. And also nice to meet you, Mr. Atkinson. And I believe UK is on the front line. So I hope things settle down and, we get to our routine work very soon. I'll just share my screen. Okay, thank you, Srinivas. And it's good to connect with old friends. And also nice to meet you, Mr. Atkinson. And I believe UK is on the front line. So I hope things settle down and, we to. Srinivas, is there a sound lag or can I start? Am I audible?
Yeah, it has been rectified. You can proceed.
Yeah,
okay.
Yeah, you can start.
Great. So good afternoon, everyone. And today's talk is on ACL augmentation. As Sri in Dhirubhai Ambani Hospital in Mumbai, it's a tertiary care center. And my subspecialty in orthopedics is just exclusive upper and lower limb arthroscopic surgery. I do a bit of shoulder and elbow replacements, but predominantly arthroscopic work. So as far as ACL injury goes, we know that non-outcome ACL surgery does restore stability of the knee, and modern day ACL surgery has definitely reduced the risk of meniscal and cartilage injuries compared to a decade or 2 decades ago. And also vis-a-vis, there is a higher percentage of this type of surgeries. Now, the goal behind a surgical treatment of following an ACL injury is to restore the sagittal plane and the rotational stability of the ligament. So that's our final aim. Like many aspects in medicine, and to just briefly give you an overview as far as the ACL surgery evolution goes, it first started in the 1800s, but it was not until the early 1900s that it really kicked off regards surgical management of ACL injuries. And ACL repair to begin with was advocated in the 1900s. Thereafter, in the 1970s, predominantly the procedures were extra-articular. They were non-anatomic, using the IT band. With the invent of the arthroscope in the 1980s, subsequently these procedures became arthroscopic, and a transtibial type of ACL reconstruction was, and it began using the bone patella tendon graft. It was, however, noted that the results were not optimal. There was increased risk of osteoarthritis. And therefore, in the 2000s, It led to a series of anatomic and biomechanical studies to revisit the anatomy predominantly. And that led to a number of different techniques for ACL reconstruction: the single bundle, the double bundle, the bundle specific technique in the 2010 onwards. And in the mid, in the mid second decade, it was type of technique because we understood the importance of biology and its role in proprioception, and that was thought to perhaps give a higher return to function and return to sports. When we started doing these procedures, I'll talk to you in my slides, and therefore it was decided to think of certain augmentation methods to our anatomic reconstruction techniques, and this is what is going to be the focus of my talk today. But of late, we have also revisited the idea of repairing the ACL. The idea is to try and preserve the native ACL as much as we can to hopefully ensure that we get even better function than what we do with the anatomic techniques in the present day. So as you note, we've gone a full circle and still, ACL surgeries. As graft goes, we started with the bone patella tendon graft. It was a wide diameter graft and also the healing in the femoral and the tibial side of the tunnel was better because of the bone-to-bone contact. Unfortunately, the tendonitis, fractures, and importantly, anterior knee pain. And therefore, although 1900s, into 2000, graft of choice, because on biomechanical studies, it was close to the force sustained by the native ACL. Typically, a semi-T and a gracilis tendon was harvested. And there were certain drawbacks, although a few, namely numbness, cramping. Size variability was an important concern. Or premature amputation of the graft during harvesting was also another concern. And it was noted that there was some weakness typically in deep flexion and internal rotation, especially in the high-level athletes. And certain studies in the late 2000s showed that the hamstring tendon was not as strong, and there were population. And therefore, in the recent past, there has been an interest in using the quads tendon. Now, the quads tendon has 3 times more collagen compared to the patella tendon, and therefore that graft is attractive. However, there are risks of patella fracture and also an unsightly scar if you're doing an open approach. But of course, these days you have dedicated low-profile harvesters, but they come with a price. So this is as far as the evolution of autograft goes. Now, phase reconstruction. Then we moved on to the more anatomic approach through the medial portal or the accessory medial portal. And in the last couple of years, with the intention of being both bone preserving and ease of revision, and also in the skeletal inside technique involving retro drilling has come in vogue. Now, as far as fixation goes, again, we have evolved from typically, screws which we used, metal initially, and then bio screws on both the femur and the tibia. Then we moved on to a contact of the soft tissue graft in the tunnels to ensure better healing. We, however, continue to use the screw on the tibial side. And of late, with the all inside, we have just the buttons and we drill sockets. So really, things are becoming much lower profile over the years. Now, the techniques, hundreds, we did what is called as an isometric type of single bundle ACL reconstruction, reconstructing the AM bundle on the femoral side and the PL bundle on the lateral side, typically through a clock phase fashion. And you can see the graft was vertical. So it did take care of sagittal plane stability. But of course, it was poor to control rotation return to sports. And also there was a risk of osteoarthritis. Obviously, less than the extra articular procedures done in the 1990s, but certainly there was a percentage of risk involved. And hence in 2000 onwards, there was a renewed interest in trying to of these, and these footprints were very well identified, and it was then decided to try and do an anatomic type of reconstruction to hopefully reduce the issues which we had with the earlier non-anatomic technique. So because the ACL typically has two bundles functioning, an anatomic double bundle was proposed, as you can see here. It did certainly offer superior rotational stability on biomechanical studies, but not to forget that it involved making multiple tunnels both in the femur and the tibia, and certainly it would be bone consuming and more challenging, especially in smaller patients with less difficult because of two tunnels on either side. And importantly, over the years, in the late 2010, there were various studies which showed that although rotationally and biomechanically it showed better control and stability, clinically there was no difference. The single bundle, which was advocated in the mid 2000 and is still being used very commonly, is being practiced. And what it involves is trying to get the center point both on the femur and the tibial footprint. What has been shown is that it is shown to improve knee kinematics on gait, certainly offer better rotational stability than the non-anatomic or the isometric single bundle technique. But for this single bundle procedure, there are various ways to ensure that we reach the aim target, which is the are arthroscopic ruler using an offset jig, some sort of an outside-in type of jig, and fluoroscopic control. Now, just this year, this very interesting article looked at 221 international high-volume ACL surgeons in the footprint whilst doing a single bundle type of reconstruction. And what was noted is that whenever the point was selected whilst the arthroscope was in the AL portal, the points were scattered, and you can see them with in the red markings. On the other hand, the ACL footprint was well visualized, and therefore it was more accurate than the AL visualization, but certainly the points were still scattered all over the footprint area. Using an offset aimer was similar, and it was only the arthroscopic ruler which showed that certainly it is much more reliable and better. But best of all was the use of this fluoroscopic technique, which really showed that we can really replicate this center point of the ACL footprint every time we go in and perform this. But we know technique like this one involves equipment. The staff needs to be trained, not to forget that it is time consuming. So, a majority of high volume ACL surgeons have still not adapted this technology in their practice. So when we or the athletic type, you can see that the strain patterns on the ACL graft were different compared to what the native ACL showed. And the aim portal technique certainly replicated the strain patterns of the native ACL. But the bargain 7 years showed that with the aim portal technique, there was a significant higher risk of failure in the early years compared to the conventional transtibial technique. So this was the major concern doing an anatomic single bundle type of reconstruction. That this type of failure was higher in young active patients returning to sports patients who on pre-op exam showed a high-grade pivot, patients presenting with genu-recovatum or generalized ligament laxity, or those going in for revision surgery. So this was the form. And this led to a variety of changes in doing the ACL, and one such technique called the ideal concept, wherein instead of the center point of the footprint, what was thought of is that we can stay in the anatomic footprint area, more closer to the direct fibers, which are biomechanically more sound. It would still be in the anatomic area, and it would still be in the low position compared to the non-anatomic isometric type of reconstruction. So certainly this technique showed that there was the center of the drill point. This position also occupied the region of the direct fibers, which are biomechanically much more stronger. But we don't have any studies, and we don't know any short or long-term results following this type of modification in the technology. So vis-a-vis, because there was a failure, especially in these high-risk groups, there were this group of surgeons who decided to go back to the bone patella tendon graft instead of the quadruple hamstring graft because it was stronger. Various studies showed that even after doing clinically, there was no major difference. The only significance was that the re-tear rate was slightly higher in the hamstring compared to the bone patella tendon group, especially in those engaged in pivoting type of sports. So in addition to doing the ideal of surgeons, predominantly from Europe, who decided to move on to doing some sort of extra articular augmentation to try and see whether that would reduce the failure rate, typically in the high-risk population. And these are two long-term studies following procedure. And what they noted is that by adding an extra-articular reconstruction to the ACL, there was no increased risk of osteoarthritis. And certainly they concluded that this may reduce the risk of failure compared to just doing an isolated anatomic single bundle ACL reconstruction. Ligament was rediscovered, the anterolateral ligament, a decade ago. And again, there was renewed interest in the anatomy in that part of the knee. And instead of doing a modified Lemaire's type of procedure, there were a group of surgeons association with ACL reconstruction, typically the Santee group. And they've published the short-term studies recently, which showed that there are no adverse outcomes on short-term follow-up. And they have advocated this type of augmentation in young sportsmen and in chronic ACL tears. But if you look at the literature which has compared these two techniques, what has been noted is that biomechanically, both of them restore knee biomechanics, but no clinical but the choice. So no one technique out of these two outweighs another. The modified Lemaire technique, however, it's important that when we fix the IT band area, it needs to be done in 0, 30 or 60-degree flexion, and the anterolateral ligament in full extension high. Now, this study from the stability group, especially looking at young patients undergoing ACL reconstructions, found that there was a reduction in clinical failure and graft rupture if LET was added to between the two groups. There was no difference in strength and functional outcomes at 2 months. And importantly, there was no difference in return to sports. So these extra-articular procedures were safe. They were not causing any additional harm to the knee in the achieve what was aimed for, which was to get back to a high level of sports and ensure that there is a very reduced risk of failures. And the important aspect was that there was no difference in reoperation rates either. this publication really summarized that currently any kind of additional extra-articular procedure in conjunction with an ACL reconstruction lacks any clear significance, and it can be indicated for patients with undergoing revision ligament laxity bottom and young patient engaged in pivoting activities. But it is also important to recognize that we shouldn't try and do the same thing again, especially when it's not making a difference. Or in short, we shouldn't make the same mistakes again. So there was location of the single bundle. It was subjected to higher forces, which is what the Danish study and the registry study showed. So if we can add some sort of an augmentation or a safety feature like a seat belt in our car, then perhaps we may especially early period when it's undergoing remodeling and becoming strong. So this concept was translated into what is called as an internal brace concept, and this is tends to be my mainstay augmentation technique in the bridging concept. Two braided or a braided suture tape across bony anchors to reinforce the ligament strength. And this is what my subsequent talk is going to focus on, because this is what I practice for my group of patients. All inside technique, one needs to know that it involves making sockets, not tunnels, being bone preserving. It also involves using cortical suspensory fixation on either side. The advantage is that you can use it in skeletally immature, also in multi-ligament injuries, because tunnel convergence, and also in revision surgery because we're making sockets which are bone preserving. So the all inside technique involves what is known as preparing a graft link, and that essentially is a quadruple semi-T. It is a single hamstring harvest. The advantage is that you don't sacrifice the gracilis median. By quadrupling the semi-T, you are achieving or aiming or getting a larger diameter graft. You're making sockets which are minimally invasive. And the important thing is it uses adjustable loops. So you can really kind is a highlight and a very attractive feature, which is what made me move on to these techniques in the last few years. So, the biomechanical evaluation of using an adjustable loop has shown that it has importance in retensioning, and also it really helps in fixation on the tibial side tends to be an interference screw. But the concern is that, when we insert the screw on the tibia, there is a slight risk of advancing the hamstring graft forward despite our best efforts, and that amounts to losing. So in essence, we really start behind even before the patient begins the stress of reconstruction. So really this was another reason why, and also women in particular, I found, the bone quality in the metaphyses was poor, and I was not happy with my screw fixation, and some I really had to put an additional staple on the cortex to reinforce my fixation on the tibial side. So that really made me move on to using a cortical button even on the tibial side, because of course, like the internal brace, we need some evidence to back its use. So if you look at the all inside technique, studies have shown that retensioning the loop is not a disadvantage. In fact, it eliminates the dynamic elongation and creep, which really ensures a strong construct. It is also shown that if you graft, it will behave like a 4-strand hamstring graft. So using the internal brace augmentation is protective to any size of graft during the critical phase of loading and healing. Also, it protects the repair, and we may accelerate our rehab. So certainly these are advantages. This type of technology showed that the fixation point was separate. It allowed independent graft tensioning both on the femur and the tibial side. It defined load sharing between the graft and the tape as a secondary stabilizer, a seat belt phenomenon. There was no stress shielding. The graft was able to withstand higher failure loads. And importantly, it was an easy and reproducible technique. Unlike an additional operative time or an additional procedure involving the extra-articular technique. So as far as the internal brace augmentation goes, it certainly reduced reconstructions by increasing or rather decreasing a percentage of rupture rates. It also prevents excessive range of motion during the healing phase of the autograft, and also importantly reduces the incidence of secondary injury. Apply to patients who are young and involved in pivoting sports, those with high-grade pivot, even in the high BMI patients. So these were patients whom we used to conserve because of their being overweight. But then they would have another injury in the it would be a more injury into the knee and further surgery, which will lead to deterioration with time. Hence, not ignoring this group and augmenting it with an internal brace is certainly a very attractive option. For the general recovery and the those with add an extra articular procedure, or if they have a high tibial slope, then I do tend to add an osteotomy to try and address their problem. And importantly, just doing an internal brace augmentation would be a very good way to deal with revision cases. So this is the technique I do. I will just show you a brief animation. So this is the tightrope adjustable loop device. It has a number 5 leading suture, which has to be removed if you want to pass in the internal brace. And it's a fiber tape suture, a polyethylene. Just pardon me, I'll just, yes. So I'll just play the video. So I'm on the femoral side of the button. I have feeded the tightrope, ensured that the two ends of the tape are uniform and of equal length. As you can see, and mounted it on the graph board. The way to hide these internal braces, because some surgeons have a concern with abrasion, is to pass it between strand 1 and 2 on one side and 3 and 4 on the other side. So that would nicely hide these tapes. But importantly, when we take the graph link at 15 and 20 millimeters on both sides, we don't take it through the tape. So you can slide the tape nicely. So again, the preparation is a very standard way to try and identify the femoral side anatomy. Go at the anatomic spot, just drill pin, now the depth of the socket to be created. And on top of this, a depth gauge here shows that the tunnel is 45, and a low profile reamer is subsequently passed. And I drill to around 25 millimeters. Socket, because I have a 20 millimeter graft on either side, and I can add 5 millimeters of retention. So you can see here, make me drilling to the 25. It's important to clear the socket mouth to prevent any impingement. Similarly, the tibial socket is prepared using a footprint jig, and the remnant, as you note behind, is preserved, so we don't sacrifice it to whatever biology it adds. And here a retrograde drill like a flip cutter is used from inside out. It's important to clear the mouth of the socket to prevent any graft impingement, because the passage in the tibial side is retrograde. Dedicated sutures are passed. Graft is delivered through the anteromedial portal. So here I'm retrieving the tibial suture first, then I'm passing the different color suture onto the femoral side. And then the graft is railroaded. So you can see the tape and the tightrope construct being delivered or pulled in by the assistant. And there are markings on the femoral side. So I go up to the 20 millimeter mark as seen here. You can note that the remnant is still preserved and it adds to reinforcement of the autograft. Yeah, so it involves a bit of suture management when you're passing it through the tibia, but I also do shoulder surgery, so it's not difficult and it is just a matter of getting used to the technique. So here you can see the single bundle anatomic autograft, and you'll see the internal brace augmentation, and it's hidden behind the strand, so there is no risk of abrasion of the articular cartilage. You can see that on either side. And then I go on to tighten the internal brace and the tibial end of the button separately. The tibial end of the button is passed, and the tape is either fixed independently with an anchor with the knee in full extension, or you can pass it through the button and tie some knots. So this is fixed independently. The knee is cycled to eliminate any creep, and then you can retension the loop both on the femur and the tibial side. And that really takes the residual slag which one tends to see if you use a tibial screw. And that's the end construct. Now, this is a reassuring second look arthroscopy at 30 months, which shows that these tapes nicely synovialize within the graft, and they really help to reinforce the construct, especially in the first year, and prevent this study, which is still in press, was a level 1 randomized controlled trial looking at a group of 64 athletes who were 24 years and younger, so really a high risk group. Had a PTB, a hamstring with an internal brace augmentation, and validated functional scores were used. And what was noted that there was no difference in outcome scores between the two groups. Also importantly, there was only 2 graft link failures vis-a-vis contra. Now, if you have come across Leo Pinchetsky's work from Sydney, he's been a big fan of the PTB graft over the years, and he's noted that the risk of contralateral PTB tears are higher when using this graft. So really using the PTB in the high risk population is not without risk. And importantly, this study also showed that the risk of kneeling pain involved with the PTB group was not present when a hamstring with internal brace augmentation was used. So I'm not saying that we have answers for an ideal ACL technique. What we are still looking for, even though we are much better than what we were, say, around 50 years ago, to restore the native ACL patients to return to the same level of pre-injury function, importantly prevent any form of joint deterioration. But such a technology is still awaited, and hopefully we'll get one soon. And to just brief you of some ongoing recent technique is using a trialing graft. Now the thought process here is that you bifurcate it on the femoral side, so you make 2 sockets which would add to the rotational stability compared to a single anatomic bundle, whereas you stick to a single tibial tunnel. But obviously there are no studies or any follow-ups for this technology. The other mentioned in my first slide was the use trying to do an ACL repair to preserve the native ACL. But again, it is only for a very, very selective population, and also the technology to repair it is constantly evolving, and we still haven't reached to the ideal technology. But certainly it is a development on the positive side. So in summary, we have improved our understanding and management of ACL injuries in the last 50 years. Anatomic single bundle ACL reconstruction till date remains the mainstay surgical techniques, and the quadruple 70 graft continues to be the first choice autograft. Augmentation with the internal brace really offers distinct benefits over a standard ACL reconstruction, certainly by reducing the failures which were noted in the Danish registry studies. Importantly, it is easy, reliable, and a very, very reproducible procedure. And perhaps the internal brace concept may be a critical step that we can control at time 0 to protect our graft and prevent it from re-tear. I'm not saying that having an ACL augmentation has answered all our questions and eliminated all our failures. There are still a lot of uncertainties, but certainly we have gained a lot from evolution of ACL surgery. Thank you very much for your attention. Hello?
Hi.
Yeah, I'm sorry. I hope you could hear my talk because I could get some message about the internet. But I hope you could hear my presentation clearly.
Yeah, there was a bit of a lag, but it was fine.
Okay, great. Good to know.
No issues. We could hear everything.
Yeah, great.
So thank you, Shreyas, for your very interesting presentation there, particularly with the background and tracking the evolution of ACL reconstruction. We followed a very similar pattern in the UK, and I'm part of the ACL study group with Arthrex in Munich. And I've been doing these kind of augmented ACL reconstructions for almost 6 years now. My go-to is the all-inside technique. Actually, I was interested to hear that you're selective about which patients you internal brace and which you don't, because I internal brace every single one. So every single ACL reconstruction gets an internal brace. I use the all-inside technique, and combining two elements of your discussion, I actually also do a lateral extra-articular tenodesis in about a third in addition. And the ones I select for that are the patients with a big pivot and particularly young male athletes. I'm just wondering whether you have an experience of combining both the internal brace and an ALL reconstruction or an LET reconstruction.
So what I tend to do, and obviously this has been known, and since you're part of ACL study group and so on, is that if you have a associated injury like a lateral meniscus tear, high-grade pivot. So if I tend to find that when I do my ACL reconstructions, I obviously augment these high pivot patients with the internal brace, but I would then assess what the stability would be like, and if it is ALL type of procedure, I don't use the IT band type of technique, but I must say that that percentage of people where I've added an extra articular procedure is really small. Generally dealing with some intra-articular is an internal presentation. That's really a suggestion that you should internal brace all our ACL patients. So it would be really good if you can kind of follow these up and present it, because it will be really interesting to, and it will certainly give a message across to people like me who selectively use it currently for only patients. If I don't get a 8 or a 8.5 in a male or a 7 and above for a female, then I would augment it. I won't sacrifice the gracilis, but I will just augment it with an internal brace. But I think what you're doing certainly makes a lot of sense, and I'm looking forward to some sort of a publication or a presentation.
So we're prospectively collecting data on a whole series of these patients. So the internal bracing you presented is the second generation, which I think everybody's now doing, where you lie the internal brace alongside the graft and you fix it independently. Previously, we were internal bracing by incorporating the fiber tape within the graft, and there were some concerns about stress shielding. So I followed up my first series of, it's about 280 patients. So at a mean follow-up of 24 months, we had a 1.9% re-rupture rate in those patients. Whereas within the 180 we've done subsequently with the second generation internal bracing, at a follow-up of minimum 18 months, we've had 0 re-ruptures so far. So I think there's definitely a change in the, obviously in the technique, but possibly a change in the outcome as a result. It's possibly also because of the learning curve that I've got better at doing these as well. The biomechanical studies certainly would suggest internal bracing smaller grafts, and every increase in diameter of 0.5% reduces your risk of re-rupture. That's been shown in the Swedish registry quite clearly. But I think it's not a step too far to consider doing something like an LET using the same type of fiber tape construct. I don't use an ITB graft for augmenting the ACLs. So actually I put a small length of fiber tape at the midpoint between Gerdy's tubercle and the head of the fibula, and then just above and posterior to the lateral epicondyle. And I put in almost like an internal brace you would use for an MCL augmentation, or for any other kind of static internal bracing. And I find that I'm doing that in about a quarter of my patients now as routine. It doesn't add very long to the operation. It adds maybe about another 7 or 8 minutes. And if you're familiar with the internal bracing technique, it's just a really straightforward augment. I can't really tell you objectively whether it's going to have an impact on the re-rupture rate. Time will tell. And as you allude to, when that data becomes clear, we'll be able to publish that. But I think from the work that Al Getgood is doing, I think it's almost a no-brainer now to consider doing that, no matter what technique you're using, because there doesn't seem to be anything detrimental to doing an LET in addition to your ACL.
Right. So when you use the tape for the extra-articular procedure, do you put it on top of some soft tissue? Because just clicking of the tape if you just put it on the bones, or have you noticed anything like that?
No, nothing. And in fact, I use internal bracing in all sorts of other augmentation scenarios, augmenting tendon reconstructions, other ligaments, and I've never had problems with internal friction developing. As you've shown, it's a very biotolerant tissue, and you get ingrowth and ligamentization of the surface of that. A lot of people put the LET underneath the LCL, but actually it seems that even if you put it above the LCL more superficial, it works. I think the key is to make sure that it's only tight in extension, lacks in flexion, and that you tighten it so it's manually tight at 30 degrees, as you would with any internal bracing and swivel lock structure. I actually double up the length, so it's 2 fiber tapes. I do a loop fiber tape. I never could justify doing a larger soft tissue graft, so some people are using gracilis, or some people are using big sections of ITB, given that the ALL is really just a kind of capsular condensation rather than some very, very strong tissue. So I think if you were to put a gracilis or other augment, I think you probably would run into some sort of friction problem, because the tissue would be just much too bulky. But I'm open to the literature correcting me on that. But so far we've had no issues at all with just using fiber tape as the LET augment.
Correct. And the soft tissue graft would stretch out if you just use a gracilis. So that would be a concern, whereas the internal brace like a tape would really be good. So no, I agree with you. I agree. So part of the technique, you just do a single strand. You don't do a double strand, because you mentioned about a tunnel on the tibial. You just do a single strand, right?
Sorry, I missed you at the very beginning. Single strand for what?
For the extra-articular.
So what I do is I get a loop of fiber tape, and
Yes.
I'll fix it with a swivel lock, so it will be looped on itself. So it'll be like a
Yes.
two fixed into the tibia, and then I take the 2 ends, put them through another swivel lock, and dock the
double.
So it's like a double.
Okay, great. Yeah, that's a good idea. That's a good idea. Right. Okay, great.
Okay.
So for the ALL, when you use the fiber tape, you place it over the LCL.
Shrey, you asking me?
Yes.
Yeah, I do. So I found that actually sometimes pushing it underneath the LCL is quite tricky. I tend to do a percutaneous approach for this rather than a sort of a big open. When I did augment it with ITB in the past, then I used to put it underneath the LCL. But laying it over the top doesn't seem to be a problem at all. Partly because it's just it's a very thin tape, so it doesn't really kind of bulk up at all. As I said, there'd be no occurrences of skin irritation or people don't really feel it underneath the skin.
And for the ACL internal brace, what position of the knee would you tighten your ACL and your brace? Is it the same or?
It's similar, yeah. So ACL I tighten it at about, we always say 30 degrees, but it's more like 20 degrees. I do like you do, so I'll tighten up the internal brace first of all, and then I'll tension the graft again, and then the last thing you tension is the graft. You don't want to stress shield the construct by tightening the graft and then tightening the internal brace, because you should be able to demonstrate intraoperatively that the internal brace is lax, and you can sort of do that with a hook. You can show, where, that it's lying lax. What I do though, I try and push the internal brace behind the graft. I could see on your 3-year picture where you've got that sort of ligamentization that was sitting in front. And I think if the internal brace is sitting in front of the graft, then it will be much more lax. And I wonder whether you're actually getting very much of that seatbelt effect. So I tend to push it at the back and try and actually put the graft more anterior to it, so that it has a proper seatbelt function.
Sure.
Shreyas, do you tighten at the same angle?
Yeah, as I you don't want to overconstrain the knee. If you tighten both together in 20 or 30 degrees flexion, you will overconstrain the knee, and that is to be kept in mind. So certainly it's a differential tightening, and do the internal brace in full extension, and then in 20 degrees or 30 degrees flexion.
Yeah. So that's the most important point. So I didn't say that, but you're completely right. You tension the internal brace in full extension, otherwise you'll capture the knee. Whereas the graft you do at 30 degrees or 20-30 degrees.
Okay.
How much does it add to the cost of the procedure?
What's the cost of the procedure?
Yeah, of course. It's very valid. Yeah, I'll let the NHS consultant talk first, and then I'll give my thoughts.
So I think I have a real problem with the work. I mean, I don't want to sort of be anti a company, but I think the way things are packaged, I think there's certainly an amount of profiteering by using, lots of extra bits of kit for every single part of the procedure. And if we have these things separately packed, for instance, the fixation anchors that I use as swivel locks, they're quite expensive as individually packed things. Whereas if you have a pack that it comes with 2 swivel locks, internal brace drill, the fiber tape and the tap, it comes to slightly more. And I'll be canvassing for packs to be made up for everything. So for instance, you have an ACL pack, which comes with, a variable flip cutter. It comes with an internal brace secondary fixation kit and kit for doing an LET, because I think otherwise it becomes very expensive. Your kit costs end up costing more than the whole tariff. So you've ended up almost doing a kind of a 3 ligament type procedure for the cost of, cost of 3 for the actual surgery of 1. So it is a problem. But, if you think about the savings to the patient, well, you're using 1 tendon, you've got a spare tendon for, doing other things. Like I often combine a posterolateral corner. You'll find that a lot of the ACLs do have posterolateral corner laxity, and you've got the spare gracilis, which you can then use instead of having to look to the other knee or using allograft. So, and you're doing a better job. So there'll be some savings on, re-ruptures, revision surgery, etc. So, these are difficult things, but we're finding it harder and harder to justify using so much kit for soft tissue reconstructions because the reimbursement's not that great compared to, say, arthroplasty. So yeah, that may become an increasing problem, but we're canvassing to the company to get us proper packs with maybe, excess equipment for adapting to all these other various adjuncts.
Yeah, certainly that's a very good idea to have packs dedicated. That will certainly reduce the cost and also the inventory. So Srinivas, to answer your question from an Indian perspective, is that, certainly there is a slight added with some sort of an additional benefit. So I think overall it's well worth it. And, in private setups, you can really negotiate the rates with the dealer. So I don't see whereas in an institute where I am, the tariff is fixed. So as you know that that's a different situation, but I get most of my patients are insured, so it's not an issue. And obviously, as Henry said, that we're looking at long term. We don't want it to come back with failures. That's a second surgery. It's an unhappy patient. It spoils your reputation. So I think overall it balances out, and we shouldn't compromise on certain if it gives better outcomes.
Yeah.
Sasi, you wanted to say something?
Yeah. Dr. Shreyas, thank you very much. It was a wonderful presentation. You took
Thank
us through the most of the evolution of ACL reconstruction, both in terms of the tunnel placement and also the choices of the graft, and also the augmentation method that have happened over time. Thank you very much. And Dr. Henry, thank you very much for sharing your experience with respect to augmentation of both the ACL and also the extra-articular component, either in terms of lateral extra-articular tenodesis or reconstruction. Thank you very much. I have a couple of questions for both Dr. Shreyas and Dr. Henry. Is there a way to objectivize the amount of laxity that you give to the tape or the internal brace? Is it only that you want to keep the knee in near full extension, and do you give a full tension on the tape, or you want to put a probe and create some sort of a laxity there?
When you get the knee in extension, yes, sure.
Yeah. I was going to say
sorry.
the same. You get the knee in extension, so I think you can't then over tension it. The question really is what happens to the hyperextenders. But I think I treat everybody virtually the same way. I don't think there's any real objective way to say you've given it a little bit of laxity or a little bit more. You tighten it as tight as it will go in extension, within the parameters of the swivel lock construct, and that's it. I think the one danger potentially with the all-inside technique is that you can over-tension the graft, and what I found in some patients is they're a lot tighter than I still do some BTB grafts than say the BTBs are at 2 weeks, 6 weeks. But I think what Shreyas was about to say. I think you need to make sure you don't capture the knee. So I think absolutely not in any degree of flexion should you tighten up that internal brace, otherwise you'll run into problems. And I don't know if you've had to release any internal braces at any stage. I've not had that problem yet, but I don't know if you've got an experience of having to go back into a knee and cut the tape.
No, I haven't had that to do, so that's really fortunate. But to answer Sashi, then the brace appears loose. So that's the important point, that in flexion, it is loose, and in extension, it appears tightened or constrained.
Yeah.
Okay, so Dr. Shreyas, do you just maintain the differential position of the knee for tightening, or you also use an instrument to keep it a bit lax?
You mean the tightening on the tibial side, like when somebody puts a screw?
Tightening in the internal brace.
20, no, I said is in extension, and then the hamstring, the tibial part of the hamstring construct is in 20 to 30 degrees flexion.
Fine, thank you. And is there a difference in the fiber tape that you use, or an internal brace that you use, or a regular fiber tape from Arthrex or any other company is fine?
Yeah, all these tapes have kind of more or less identical. The composition is same.
Any fixed width, width of the tape we should not exceed, or is it? Is there any guidelines on that?
No, see, what matters as far as the tape goes is the strength. So, if you get an industry is moving on to narrower tapes with the same kind of strength, so they become even more low profile, less of a chance of abrasion and so on. So as long as biomechanically the strength is identical, you want the narrowest tape possible. But you can't go beyond a certain narrow width At the same time, they wouldn't go to a wider version because they've tested this and they found that this is quite, advantageous. So they will not go to anything wider than this.
So yeah, I agree with that. I think the danger if you went too narrow is that it would actually almost act like a cheese wire or guillotining. So I think that's one of the nice things about the fiber tape. It just happens to be about the right sort of dimensions. I haven't done any internal bracing using suture tape, which is a kind of a much narrower device. I don't think it's as strong either, but I'm using suture tape more for graft preparation. So instead of using fiber wire now, I'm using suture tape. I think it's a bit kinder to the tissues.
Okay, Dr. Shreyas, you showed a beautiful arthroscopy video showing that the tape is sort of integrated along with the graft. Had there been any situation when you felt the tape has created more irritation rather than getting incorporated?
No, not really. And again, as Henry alluded, one of the ways to prevent that from happening is to incorporate the tape within the graft. So, you hide it or put it at the back. So then that possibility is eliminated.
Okay.
Is it possible only with an all inside technique?
No, I mean, you can do it with a cortical fixation on the femur and a screw on the tibia. It's just that you will need to again do a differential tightening and so on.
So
I think it is possible.
With the tibial screw, how would you?
No, so again, you put the tape first, you fix the internal brace, and then in 20 degrees or 30 degrees, you pass your screw really.
Okay, so so you use a different fixation, post fixation for the tape and screw for the graft, right?
Yeah, as you saw it on
I think you need a differential fixation. I think if you were to put a screw in, then the screw would hold both, and then it would kind of defeat the point. I've not done an internal brace using screws at all. So I don't think, I think the concept would be different. I think you can't really use that. What I'd say in revision cases, so the ABS button is quite good because actually it allows it to sit on bone. But I've got a low threshold for using a button extender on both the femoral and the tibial side. And I think through experience, let's say, if when you're drilling the bone, and this is particularly in girls actually, if when you're drilling the bone, it's very soft, then I'll automatically put a button extender on because you can have a pull through on the femoral side in particular, and I just don't want to risk that. And I'll do the same on the tibia. I won't, don't mess around. Because I've had a few occasions when I've been tensioning the graft and actually it's pulled through the femur at the time of surgery. And I encountered one from one of my early series where the graft, the tightrope pulled through the femoral side about 4 months after surgery. Weirdly enough, actually, even though the patient had laxity, they were still stable. So we didn't have to do anything about it. But he had soft bone as well. So I think you need to be careful with the cortical fixation, no matter what button system you use, because the bone is only so strong.
Okay, and with respect to all inside fixation, Dr. Shreyas said one way of fixing the tape on the tibial side is to have it taken around the button and have a knot around. Is that good enough? Other than using an anchor in case you want to reduce the cost of the surgery?
I mean, I guess you can. I mean, there's no, let's say there's no real science behind it. There's a limited amount of science behind it, and whether it translates to clinical outcomes, we're still watching out. I tend to do things in a kind of purist way because there is a theory we're trying to keep to. I guess it wouldn't do any harm to do it, but then maybe you're losing some of that differential tightening, and maybe it's losing some of its actual seat belt, role. So I would always fix it separately.
I agree, yeah.
Yeah. Okay, Dr. Srinivas, anything else?
It was a wonderful presentation and a good session of question and answers. Thank you very much for all the answers and the presentation.
No, great. I mean, from what it appears with Henry's contribution in the discussion part, really, he's quite well versed with this type of a procedure. And certainly it'll be good to connect with you at some point. Henry, I'll get your details of Srinivas, and then, you know, it'll be good to keep in touch. But no, excellent.
Yeah, definitely. It's an evolving field. You know, things are constantly moving. So, you know, I think, and getting other people's experience. I mean, I learn from others all the time. And, you know, I think as we move forward, I think, and the technique evolves, I think that's vital, really.
I think there is always something for everyone to learn every other day. So it was a great learning experience. I would love to learn from all of you. Thank you very much for making it happen.
Listen to your technique as well. You use PRP as well, isn't it, along with internal brace? So maybe we'll get you to present your technique in one of the presentations.
Yeah. Yeah, I put some pixie dust in as well now, just for, you know, added value. Science is definitely flaky on that, but it's, you know, it might just help, you know.
Sure. No, great. Thanks, Srinivas and Sasi, for the invitation. It's always a pleasure to us, you know, connect with you guys, and you're doing a great job. So keep it up.
Thank you very much. Thanks a lot.
Great.
See you
Thanks.
soon.
Looking forward to connecting with you, Henry. Take care.
Yeah, definitely.
Bye-bye. Bye-bye. Bye.
Bye.